Welcome, everyone. It's my pleasure to welcome you to the fourth of our four-part series on championing best health, a primary care series on pediatric obesity, hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher, and I'm the Associate Dean for the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing best clinical care for patients. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, Anishinaabe, and Saulteaux lands that are now known as parts of Treaties 6, 7, and 8 in the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I'd like to start with a little bit of housekeeping information just to remind everyone that if you have any questions about a technical difficulty or L3 programs or services, please use the chat feature on the bottom of the screen. If you have questions for Laurie and Stasia, please use the Q&A feature of the webinar. Please review what's already been asked and upvote those questions you'd really like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent via email to all those that registered together with our PEARLS documents. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. For more information, please visit the QR code on your screen. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we are thrilled to welcome back for the last time, sadly, Dr. Stasia Hadjiyannakis and Dr. Laurie Clark, who are going to be presenting part 4, When Care Gets Stuck, Strategies for Overcoming Roadblocks. And we've introduced you to Stasia and Laurie before. So just briefly, Stasia is a pediatric endocrinologist and medical director at the CHEO Center for Healthy Active Living and associate prof at pediatrics at the U of O. And Laurie is a clinical psychologist and clinical investigator for the Center for Healthy Active Living at the Children's Hospital of Eastern Ontario, where she works with an interdisciplinary team to help children, youth, and their families achieve their best health. So with that, I'm going to turn it over to you two to help us get unstuck in our clinical encounters. Thank you.
Thanks, Denise. Stasia, we didn't really talk about which slides we're going to do, so I'm just going to throw some to you every once in a while. Thank you for joining the fourth session with us. If you guys have questions or tricky situations that you want to throw in the chat, we're going to try to leave some time at the end to talk about things that you folks bring up. So we're just going to do a brief review of the 5 A's and how to tailor interventions, and then talk about some sticky situations that were either raised by you folks or ones that we know people that, kind of take us on a bit of a different pathway with patients. So we're going to talk about how to talk to youth about medications and surgery within the context of sort of a health at every size, weight neutral approach. How to talk with youth who are dieting and struggling with body image, talking with weight focused parents, and then how to sort of adapt when our patients have ASD or neurodivergence. So just a quick review of the 5 A's. We've covered all of them so far, so we want to ask permission to sort of raise the topic of weight management, spend, if we're choosing where to spend our time, it would be on the assessment and looking at all aspects of health, so that we can talk with our patients about their realities and what their health is, and then helping them to come up with a plan together and assist them in carrying out that healthcare plan. So we talked about Alex. We've talked about Alex a few times. He's our 12-year-old with a BMI of 34 and an EOSP stage 1. And the M's that put him sort of in that stage 1 level are some mild body image concerns, perfectionism, emotional or boredom eating, and then stressors in his milieu in terms of parental separation, communication difficulties, and parents having different approaches to feeding. These were the sort of 4 M's and drivers and barriers that we came up with at assessment. Stasia, do you want to add anything or highlight anything?
No, you're
No?
doing great.
Okay.
I think
So maybe we'll just move then to the care plan for Alex, which I think from the assessment and looking at the 4Ms and barriers and drivers, there is a focus that sort of popped out were sleep and snoring, the boredom eating and diet history, body image and perfectionism, and then parents' approaches to his social isolation and feeding. So if we look at first steps, and again, there's probably many different directions we can go in with patients in terms of their health, and sometimes thinking about where we think we're going to get the most bang for our buck in terms of change to their health, where kids and parents are motivated to make the change or feel that, you know, where things might need to start and finding that balance. So things we could take first steps in those agree and assist A's of the 5 A's would be to refer for a sleep study. Can we refer to a dietitian if there's one within your family health team, or if there's if families have uh, what's the word I'm looking for? Extended healthcare benefits and can afford to go to a dietitian. We do usually kind of, after a while of seeing patients and working within the 5 A's, folks tend to sort of gather a bit of a list for their clinic of who are the dietitians that tend to work well with this population, who are the counselors or therapists or resources in the community for the mental health and body image, and usually when body image is an issue, we usually tend to look for therapists who have some experience with eating disorders, because they tend to take a more weight neutral approach and avoid any messaging that sometimes can come up of, oh, well, I think your depression would be better if you moved more, lost some weight, right? So we sometimes it's helpful to have that list, or ask your colleagues if they know who in the community might be a referral source. So can we send them to or recommend a dietitian to set some SMART goals around the boredom eating and provide some education about why dieting isn't a good plan? Again, referral to a counselor or therapist, but also spending some time maybe giving some resources or talking yourself about the difference between health versus weight. And then gently suggesting and maybe talking to parents about finding some common ground in terms of an eating approach. So that, remember, Alex was one where dad was, I think it was dad was sort of trying different diets at home, and mom then was sort of trying to compensate the other way. And then we get into sort of food sneaking or overeating at mom's because we have access to the preferred foods. So those are the things that kind of stuck out to us as first steps. And so we want to sort of, if anybody else has any other suggestions or questions, you can throw them in the chat around why, we would kind of start with these areas for Alex. The next kind of topic we were going to address was how do we talk with our patients about medications and bariatric surgery within sort of a weight neutral approach, and we really struggled with this at the beginning when medications became more available for youth, is how do we suggest a medication for weight that's and very publicly marketed as a weight management medication, when we're also giving the message of this isn't about weight, this is about your health. So, and Stasia, we're going to do a role play. I didn't tell you that, but do you want to talk a little bit about how you go about talking about this stuff with patients, particularly around the pharmacotherapy, I think?
For me, I really rely heavily on my EOSP stage. So before, of course, giving any advice around intervention or management strategies, you want to complete your 4Ms assessment and complete your clinical stage. So for someone like Alex, in Canada, we have the approval now, Health Canada approval now for GLP-1 agonists for those 12 years of age and older, with a BMI above the 95th percentile or 97th percentile using the WHO growth curve. So technically, our patient Alex does meet criteria or is eligible for a GLP-1 agonist. For me, if a young person or parent asks about medications, then I would go through discussing whether or not medications may or may not be medically indicated for the young person by going through the 4Ms. So let's think about this. Does your body need any assistance when it comes to weight management right now? And the four main areas of health that can be impacted by having a higher body weight are metabolic, biomechanical, mental health, and social health. And really, from a health perspective, the things that may improve with medication are really your metabolic and your biomechanical health. So we review the blood work. Do you have any metabolic health issues? Some of those, of course, can improve through lifestyle intervention without need for much weight change. So it's certainly completely appropriate to kind of give lifestyle intervention some time to see some change in metabolic health. Biomechanical health complications are more challenging. And so if a young person is experiencing biomechanical health complications that are barriers to weight management for them, then there may be a role for medication at that point. But it's really about function. So we try to kind of frame it around functionality and quality of life. So will the addition of medication help physical functioning throughout the day, help improve quality of life? Is it getting in the way of things like activities of daily living or other important goals in the young person's life? Where I struggle, of course, is the mental health piece, and I know Laurie's here on the call. So sometimes I struggle when a young person might say, well, I think I'll feel more confident and I will feel more comfortable. My mood will improve with weight loss. And that's when we sort of make sure to also come up with a strategy to help improve that part of their health, independent of weight change. Because we know, I think that although a young person may presume things will improve with weight loss, we know that unless we help support positive mental health concomitantly at the same time, then it's unlikely, although they feel that weight loss would improve those things, I think they're often left feeling disappointed that things don't improve in the way that they want. So I'll pass on to Laurie in terms of how we approach things. If it's physical improvements and functional improvements, metabolic health improvements, that I think there's definitely a role for GLP-1 agonists, and they can be quite helpful. But where I think it's more challenging to navigate is when the young person is saying that I want weight loss to improve my mental health, and that I think is tougher to navigate, and I'm not sure of the role of medication in terms of weight loss medication when it comes to those particular challenges.
Yeah, I think in terms of, I think in my mind, there's sort of two, as we've worked with more kids who are on these on medications, GLP-1 agonists, but also more kids who've had bariatric surgery. I think there's sort of two parts of the mental health that to think about, and one is that we know that, and our colleagues at Sick Kids who actually do the surgery in Ontario for us would say that we all see that, and research shows us that the mental health impact in terms of anxiety, mood, self-esteem does not seem to improve with bariatric surgery. And I don't think we've seen it improve just with weight loss from medications, because it has to come from inside. And if anybody's worked with kids with eating disorders, it's sort of the same thing. The weight loss sometimes is never enough, or if we plateau, or if it's not doing what we thought it was going to do, the mood stays low, and so does self-esteem. They continue, and then anxiety can also increase, because if we do lose weight, we tend to get lots of attention for it, and it might be positive attention, but the anxiety can go up in the sense that, hey, I don't like being the center of attention, for those anxious kids who don't like being put on the spot. But also now everybody's commenting on your body and your weight loss, and so fears pop up of, what if I regain the weight? What if we can't afford to keep doing this? So fears and anxieties can continue or crop up if we're just sort of one of those, people who are sort of either temperamentally or genetically predisposed to anxiety. It will find things to worry about if we don't treat it directly. The one thing that does, I think we've heard, and I don't think there's a ton of research, but we've heard it, and other centers have heard it as well, in terms of the food, what people call food noise. So does sometimes get better with both bariatric surgery and pharmacotherapy, and for others it doesn't. So by food noise, what I mean is the thinking about food, or the sort of preoccupation with food, and did I eat the right thing? Did I not? When am I going to eat again? Is someone going to say something? That food noise seems to quiet down for some people, but it's not all. So we need to be realistic, and you might say it, and kids will be like, I don't care, because I will feel better if I weigh less, right? So it's making sure parents understand that reality, and then seeing if you can get some agreement of, okay, so that might be true, but there's also going to be changes along the way. So can we, at the same time we're, working on medication or bariatric surgery, can we also just work on your mental health itself? Do you want to do a role? Sorry, go ahead.
I think that's good. I think it also can be a bit disorienting, I think, for young people after they've lost weight, in terms of that. And I'm sure for adults as well, I imagine, just the change in attention. Now, it's not clear if they're also presenting themselves with maybe with a little bit more confidence. It's not clear, but the additional attention, or the positive attention, for some people, in their minds, they're like, I'm the same person. My body now looks different, but now I'm getting all of this. Why all of this positive attention that I didn't get before, and it can be disorienting, and I think quite painful to have that experience as well. I think
Yeah,
we
it
should go
might be.
on. Sorry, I don't. I think we should. Yeah, yeah.
Yeah. Do you want to do a role play or do you just want to move on to the next?
I think we'll go to the next slide. Yeah.
Okay. So another question that was posed by someone in the group was, how do we talk about dieting and body image when we have a patient maybe who's been engaging in sort of dieting behaviors, really concerned about body image? How do you talk about, you know, um, making health behavior changes without and having that be different and differentiating it for them from a diet per se. And I had this from a parent last night in a parent workshop on body image that I was doing, is to like, how do we call it a diet? Do we not? Because, you're saying we don't want to focus on the weight. So how do we do this? And so I often we talk about giving a lot of sort of education on um, why diets don't work in the long term when we think about restrictive diets, and depending on the kid and the family and previous experiences, if they have kind of done diets before or seen mom and dad do them where their weight kind of goes up and down, because after they stop the diet it's not sustainable for whatever reason, it goes back up, to talk about why that makes sense and it's not a failure on their part. It's that the diets don't work, you can't do them forever. And I also talk to them about, when we're on a diet, we're now not following our body and our internal cues for hunger and satiety. Instead, we're following um, a plan that somebody else has laid out, and that may not be what our body wants or needs, and so we really want to help them have a good relationship with food and get back to sort of listening to their body a little bit. So we want to provide a lot of education and then assist them in addressing the root cause of why they're dieting. So, is it body image concern? Is there bullying and they just want the bullying to stop? We hear that quite often is, well, if I lost weight, the bullying would stop, or people wouldn't bug me about it, or my mom wouldn't make comments about, my weight and things like that. Or they just feel I would feel better. And so sometimes spending a couple minutes, okay, tell me about that. What is it? And sometimes it's lovely when it happens that kids or teenagers kind of work themselves back around to to going, oh yeah, this, it shouldn't matter what somebody else thinks about me, or that's actually not really important when I think this all through. But to talk about, if it is bullying, then we need to advocate for them, or talk with parents about advocating for them, whether it's at school or at another sort of organized activity, or whether we need to help them see somebody around feeling good in their body, and increasing self-esteem. The other important thing, which we'll talk about in a minute, is just making sure that we're addressing weight bias and weight talk in the home as much as you can, without going home with them and having dinner with them. But if there's continued weight talk in the home and weight bias, it's really it's like going home with the person who's teasing you or bullying you, right? And sometimes it's about talking with parents about making sure that siblings are not um, you know, making fun of the child for whatever, or using that to, push their buttons. When parents have a lot of weight bias or weight preoccupation, I think we always come at it in our clinic from a place of, we're going to assume that parents are making the comments because they want what's best for their child. So they're not meaning to be mean or cruel. They're trying to motivate their child or get them to see in some way, why they need to be concerned about their health and their weight. So oftentimes we'll take a step back and I'll say, okay, so what do you want most for your child? What's most important to you? And, usually we get to, a place where they very quickly kind of say, I want them to be happy and healthy. Okay, so I understand that, and I know the bullying is difficult right now, or you're worried about their health. Um, but I don't think that the comments you're making or the focus on weight is really moving us in the right direction. It's not getting us where we want to go. And so if parents have had their own experience with, sometimes in the conversation, they'll naturally come up with, well, I remember what it was like when I was young. I don't want my kid to get as big as I was, those sorts of things. If you have a moment, to ask, what can you tell me what it was like growing up for you? What were your parents' approach to food and feeding at home? And, you know, um, what would you have liked your parents to do differently or say differently, right? And oftentimes that's what sort of clicks for a lot of parents is, oh yeah, I hated it when my mom, we've all had that moment where something comes out of your mouth and you're like, oh, that's just like my mom or my dad, would say. So if it's sometimes it's that kind of has parents click into, oh yeah, I used to hate this, and I used to hate it when people would make comments about my body. And that's what kind of gets them to move forward on this and to say, I understand your concern, but when you kind of share your concerns in this way, it actually just does the exact opposite of what you want, what you're hoping for. And we know that, there's lots of research now to tell us that weight blaming and shaming doesn't work. It doesn't motivate people. Having a poor body image does not motivate people to engage in health behaviors. And so we really want to kind of help parents to see that as well. So we want to help parents make, really encourage them to make home a safe place. Especially if there's food sneaking and things, we recommend that parents don't kind of bring it up and get upset about it. Comments about, what they're eating, their weight, appearance. And sometimes it's hard for parents, I know, to walk the line of, a kid comes down in an outfit. You don't want to sort of make a comment about it if it's about their weight or you don't want to body shame them, but at the same time, sometimes parents are like, I know, but they're showing too much skin or for anybody, right? And so it's helping them to say, you need to figure out how to say that without your kid automatically going to, this is about my weight. And again, making sure that, siblings are not pushing each other's buttons by throwing, appearance or weight-based insults around, just like we wouldn't probably be okay if, one kid had a learning disability and the other one kept throwing that in their face all the time. And instead, we want to help parents like really focus on the positive, pumping their kids up. And when we talk about complimenting kids, we need it to be specific and kind of realistic and fact-based. So it's not like, oh, you're so smart, because that doesn't tell a child what they've done or what they're being praised for. But it's like, I know it was hard for you to go and try out for a new thing, and you were nervous. I could see that, and you did great, buddy. Like I saw you really trying. How did that feel? Or, and sometimes when we talk about this stuff, people think we're not supposed to comment at all on how people look. Yes, you need to tell your kids they look handsome, beautiful, until they roll their eyes at you. And moving it to, you look beautiful because you look confident. I know that outfit expresses your personality, or you worked really hard on your nails, that kind of thing. So one of the other topics that came up was talking about how do we adapt our intervention style for kids who have ASD, or sort of have some people would call neurotypicality, or even mild intellectual disabilities sometimes when we have that really rigid thinking and difficulties with change. So this is James. Do you want to talk about James,
Yeah,
Stasia?
sure. I'll introduce you to James. He's a 15-year-old boy. He actually came through CHAL twice. He came to see us when he was a young child, like 6, 7 years of age, completed programming, and then was transitioned to the community, came back as a teenager. So when we saw him the second time, he was 15. He had class 3 obesity with a BMI of 61 and an EOSP stage of 2. He had some predisposing biologic features that contributed to obesity, including being born large for gestational age. We didn't know a lot about biological family history. He was adopted. He had coexisting ASD and ADHD, and his body size was interfering with activities of daily living for him. And he was having experiences of bullying. He had some access to activities that were adapted for people who were with neurodiversity, including Special Olympics. When talking about appetite, he'd noticed high hunger after school with feelings of loss of control, and could describe emotional eating, and notice that if he'd had a bad day, he felt more hungry, wanted to eat more, had strong cravings. He was also on atypical antipsychotic medication, which could be driving some of that hunger for him, but also on a stimulant for ADHD. Next slide.
Oh,
We did
sorry.
no, it's okay. We did the 4 M's for him. And so he had from the 4 M's, he had stage 2 from a mental health perspective, given the diagnosis of ASD, ADHD, and he had he had significant anxiety and emotion regulation, difficulties with emotional eating. Biomechanically, he was struggling with difficulties with activities of daily living. At school, they had made some accommodations for him in terms of furniture and desks desks and chair sizes that were appropriate for him. He already pre-existing had some balance and coordination difficulties, so physical activity was always a little more difficult for him. But metabolically, he had mastoid or fatty infiltration of the liver and gallbladder stones. Interestingly, he had early onset obesity before age 5 with this very high interest in food. So it was worthwhile, I think, to explore for possible monogenic forms of obesity for him. And then, of course, he was on the atypical antipsychotics. So stage 2 metabolically as well. And then from a social milieu, he had past experiences of bullying. As he transitioned to high school, things improved. That sometimes happens in our experience. Like the bullying tends to be quite overt in childhood, I think. And then as they become adolescents, it becomes more subtle, more social isolation sometimes, or exclusion, where you can't name it. It's almost sometimes can be harder because you can't actually name it as bullying as clearly. And he subsequently had limited peer connections, perhaps related to his ASD, but also his obesity, I think. Parents, dad had some struggles with anxiety, which affected his parenting a bit, but generally we're well supported at home and in school, and engaged in some interesting activities outside of school as well. So overall, stage 2. Next slide. So for him, we thought drivers were polygenic obesity, likely high birth weight. The atypical antipsychotics were probably driving things as well as impacting his metabolic health and emotional eating. Some barriers for him: pretty selective food preferences, anxiety with limited peer connections, some balance and coordination difficulties, and some emotion regulation difficulties. So it was sometimes, with that emotional regulation difficulty, sometimes difficult for parents to kind of set limits sometimes, because it might escalate his emotions, and change in the context of his ASD can be hard to implement. So we thought areas of focus at the time trying to gain some supports for his emotion regulation and maybe get a medication consult through psychiatry. We did refer to genetics for assessment for monogenic or syndromic obesity, work with our dietitian Anna around hunger and craving management. So making sure he's eating regularly throughout the day, staying ahead of his hunger, and thinking of other ways to cope with those strong emotions to kind of potentially just kind of place the emotional eating or replace some other strategies to cope with those emotions. In James, I did review pharmacotherapeutic options for weight management even at our first assessment, given the coexistence of some significant metabolic and biomechanical health issues, as well as the presence, the fact that he had atypical antipsychotics on board. So we did talk about metformin and GLP-1 agonists at that time as well. Next slide.
Yeah, so I think when we think about weight management within the context of ASD it really is, we need to think of and having conversations with parents about balancing priorities. Because oftentimes when we see these kids, parents have worked really hard and overcome a lot of obstacles. If you think about change being difficult, even getting kids, their morning routine is oftentimes for these kids is very specific. And if something throws them off, it can really kind of derail the whole day. And so parents often get to a point where they're afraid to try to make changes because they're afraid of sort of how disruptive things can be. And again, generally, we don't want to avoid challenging our kids because they might not like it. But with ASD, when there is that emotion dysregulation and really rigid thinking, little changes are hard. And so it's balancing our priorities in terms of the antipsychotic medication use. If we were just looking at the weight aspect, we may say, no, this is, we should get off this. But in terms of a quality of life and having kids be able to manage at school or manage with other kids and engage in activities in daily living, we probably need that medication. So we need to kind of balance and ask parents what their priorities are. And it may be first, parents might say, we really just need to work at, getting back into getting school and getting the school support set up. And then we can look at changes. And then when we are making changes, suggestions for changes to, increasing physical activity or trying a new activity, trying new foods, it's really slow and steady and doing one at a time. Often dietitians will do what they call food chaining. So we start with something, whatever food they like. We know where we kind of want to get them to a similar food, and we just do little variations until we get there. So an example might even be, if we think big term, I'm thinking of a child, and it wasn't in our clinic, but an eating disorders clinic who would only eat specific French fries, like the McDonald's French fries is the only thing that this kid would accept. And when you're underweight, parents will, okay, this is what we're going to give you. The food chaining looked like, let's try other kinds of French fries to start, right? And can we just have a variety of French fries and open up that way? And again, working with an occupational therapist, dietitian, or their ABA specialist to sort of work at allowing for change, right? And so sometimes advocating for parents or making contact yourself with, if they are involved in ABA therapy, to ask that maybe one of these goals might be appropriate for their work within that therapy. So when we're looking at key ingredients, we really want to be the turtle or the tortoise. I think this is a tortoise. More so than than the hair, because usually the hair ends up kind of getting kicked back to the start in this situation. And so we really want to talk about slow, manageable steps that families and kids can continue doing long after they've stopped seeing us. Stasia, did you have anything else to add?
And I think the tortoise is a good spirit. It's a good sort of um, uh, guide for clinicians too, like reminding us that we also don't in the same way that we manage other chronic conditions, kind of taking being there, being that slow, consistent, steady support for our patients and families. And in your busy practices, I think also to know that in weight management, you can take your time. If you're working on sleep over a few months, or longer, that's okay. Or hunger management, the next 4 to 5 months, or and so forth. I think giving yourselves and your patients permission to kind of go at a slow and steady pace where you can see some success, um, rather than having to face sort of yeah, three step, moving slowly forward rather than being pushed back, as Dr. Clark said. So, but I think we could leave it open for questions now, or cases that you've maybe brought today that you want to a chance to discuss.
Oh, thank you so much, both of you. So, folks, please feel free to pop questions into the Q&A, and Natasha, in the background, I think maybe people could even put up hands if they have cases.
I did want to just mention just today, I think today, the Canadian Pediatric Society put out a statement. I think it was the adolescent health group that you might find helpful, that references some of the perils of dieting in adolescence that you could potentially refer to if you do have parents or kids asking about different diets. So a
Yes,
nice reference.
Stash, I was just Googling it, and it looks like there was a piece in the Globe, but I couldn't actually find the statement.
Oh yes,
Maybe
it's
we could maybe add it on the pearls, or
yeah,
send a post a link.
perfect. Yeah, it's on the CPS website. I'll send it on to Melanie. Yeah.
Oh, that's awesome. I think that's really helpful. So folks, don't be shy. I mean, I'll kick us off with one. So I've got a couple, but one of them was a case where there was two siblings, two sisters in the family, and one was really struggling with weight and one was not, and just really different biology. But it was creating all sorts of challenge. Because the one that was not having issues with weight was super hungry all the time, doing lots and lots of activity, and so it was creating a really challenging food environment at home that way, and just a really strong, like, why do I have to deal with this when my sister doesn't have to deal with this kind of dynamic? I just wonder how you might approach that kind of a story.
Yeah, I think we've had, a handful of times, families where one child is within our program and another is either actively in the eating disorders program at our hospital, or has a history of eating disorder, or again, yes, has another reason why they need a lot of nutrition, and a different way of eating. And so working with, the child who, I think it's working with the family, and the messaging is around, you know, food is sometimes medicine, and so and fuel, and your bodies need, we need to fuel your bodies differently. Your bodies have different needs. Just like if one of you had a learning issue or needed extra help with, learning to ride a bike, we would do things differently for each of you. And so, um, you know, your sister is having trouble and, gaining weight or maintaining weight, um, and so needs to have a different way of fueling their body than you do. Is it fair? No. Does it stink for you? Definitely. So also allowing them, the child who maybe who's on the higher end of weight, is to really just let them, acknowledge that this might seem unfair to them.
Mm-hmm. Cool. Yeah, thank you. Okay, folks, I'm not going to come up with all the cases.
At the same time, Laurie, there's quite a lot of similarity between our approaches and the approach that our colleagues take in eating disorders, in terms of the goal is really to care for our bodies and feed or fuel our bodies with healthy nutrition, and we don't necessarily have to feed differently. Could you speak to that? Sorry, you would probably think better.
Yeah. So
Yeah.
it's true. It's not that, sometimes we have your sister needs really high calorie food. So that's why I always take her to Starbucks or things. And that's not actually probably what that child, there's a range of things they could eat. It's about fueling, it's treating your body, it's meeting your body's needs, and having a good relationship with your body. And I think, if there is an active eating disorder, sometimes it's almost easier because you can kind of get sometimes both kids to acknowledge, yeah, we both are having trouble liking our body right now. And so talking with parents about having similar food rules within the house. Everybody needs the treat foods at some point. If you put them off limits, it backfires. Both kids need those, to be able to eat them comfortably and not feel like totally guilty or totally like they've lost control. And find other ways within the system for them to feel good about themselves and for things to feel fair when it can be, right? The same way we do with other things for kids when, somebody might need a little bit more support or time from parents, around certain things.
Mm-hmm. Great. Yeah, so another scenario was one some years ago with a family that was in pretty vulnerable circumstances and having to get some support from food bank and the like, and some issues with parents with diabetes at the same time, and then real problem with weight gain in the little one. That age, I think, was around 6 or 7. So strategies for when the milieu is not helping, like when how would you approach that with kids around being able to actually access foods that you might be perhaps better?
Yeah. So it's that they don't really they have some food insecurity.
Yeah.
Okay. And parents who may need to eat differently because of their diabetes.
Yeah.
Yeah, it's tricky. Oftentimes it's if there's I don't know if you guys have the breakfast programs in schools, but oftentimes, asking, okay, so what do you go to the breakfast program? Okay, so what kind of options do they have there? What do you usually choose? Could we maybe, add if they're kind of having if there's not a protein in there or a milk, like could they add, if it's available, what's available and what could they add in to kind of round out a breakfast that has 3 food groups kind of thing. And then yeah, talking with parents about, ways that they can, things they can make or meals that using what they get at the food bank, right? How to balance that out. Our dietitian often talks about frozen fruits and veggies being much cheaper than the fresh, and so assures parents that there's the same nutrition often in those, and as long as they're not kind of packed in a syrup and things like that. So can we use those ways of getting those nutrients in?
And then I don't know what's available in Alberta, in Ontario. I imagine there may be similar, but in Ontario, kids with class 3 obesity or class 2 or 3 obesity, sorry, we've been successful at getting the program here is called Assistance for Children with Severe Disabilities, through which you can gain some extra support monthly for parents for things like groceries, clothing, which can be often more expensive. It also, kids with class 2, class 3 obesity here in Ontario qualify for something called a special diet allowance. So if we have parents who are on Ontario Works or unemployment insurance, we are able to then try and gain some extra supports that parents may not have known was available or is available. The other thing that our patients, depending on the complexity, may qualify. Parents may qualify for a disability tax credit. So just exploring what other resources might be available, and knowing your community. I guess knowing your community, you may, as primary care physicians, know what's available in your community beyond food banks, and other sources of support. I know Ottawa has also the City of Ottawa has a special program to help decrease cost for City of Ottawa activity programs. So just that would be sort of a nice, if you're having patients who are dealing with significant social stressors, trying to explore what is available in your community that could alleviate some of those stressors for them. But certainly, I think to add on top of the social stressors, to add on top the stress of making sure as we're approaching patients and parents who are living with these kinds of stressors, that we're not adding, I think, to this stress by making, I think they'll naturally feel maybe even more sensitive to feelings of guilt or shame in this context. So just kind of being mindful of that too.
Yeah, I think that's absolutely very true. Okay, those are a couple cases I have. I'm looking at the attendees. Allison Connors, I know you have vast experience. I'm looking at you. Fozzie, I'm looking at you too. So anyway, please feel free to chime in. Jamie, I see you there. So a bunch of people I know that have done a lot of work in this space. So if you've got anything to chime in, pop it in the chat.
Or even pearls of your own, like things that
Or
you
pearls,
found. Yes.
pearls of your own as well. Yeah, no, awesome. Yeah, no, I think one of the things I struggle with while we're waiting for other people is, Laurie, what do you do with the hoodie? So, you've got the 13-year-old or 14-year-old in the office. They've got the hoodie pulled forward. They've got their phone and they're not looking at you and they're monosyllabic if they actually answer you and you're sweating and you're like,
Yeah.
I knew you when you were 8. You used to talk to me, but now they're not talking to you. How do you break through that with these adolescents?
It's either the hoodie or the wall of hair, right? Um, so depending on the kid and how well I have, I can think of one or two kids who had ASD, who them just scrolling their phone was their coping strategy, was like their fidget. And so they were actually listening, but it didn't look like that. Other kids, though, I will say, could you just put down your phone for a second? I swear I'm not going to take a lot of your time. And see if you get anywhere. I don't get fussed anymore about eye contact, unless we're working on social skills. But I just assume even if you're not looking at me, it's okay. It's especially with kids and teenagers, you never know what, like, I think we assume that if they're not looking or they're scrolling, it's not going in. We've all had those experiences where you've said something and it comes back to haunt you, either with your own kids or with a patient, and they're like, well, remember when you said this? So it does go in, and it might not be apparent in the next 5 years, but it has gone in there, and they will tell their friend or something else, or they just get it. So don't get discouraged if there is no eye contact. Also, though, I think you can ask, like, hey, could you put your phone down? I won't take too long. You can tell me when my 5 minutes is up. Or I do the motivational interview. Can I ask just one question? And usually they'll say yes. And then if you get them talking, you can push it a little bit. But it is hard. If you can figure it out, Denise, you've got a moneymaker there.
I'm getting close to retirement, Laurie. I don't know if I haven't figured it out yet. I think I'm hooped, but no, it's just really it's just really difficult, right? Because these are tough conversations, and you want to try to unpack what's actually happening from their perspective, like and it's hard to do if they don't speak to you. So yeah. I don't know if
Yeah.
anybody else if this resonates with anybody else on the call, but this is my experience with them.
I know if you can find if you can find a way to connect on a level that's not maybe related to the reason that like the medical appointment, also like finding things that they're interested in, even if you've got clues from what they're wearing, like maybe a concert t-shirt they're wearing, or something that you can break the ice with that has nothing to do with the medical issue, and get them talking and showing an interest in who they are as a whole person. I think that's a way in it. And I think Laurie made a really important point in that. I think that it is percolating, and I don't know. Many of you have been in practice long enough, maybe, to have patients come back, 5 years later, 10 years later. We've had patients come back, when they're in their 20s, telling us that, kind of letting us know what that experience was with us in their teens, and it can feel really nice to know that, yeah, some of that came out, but maybe they weren't ready, at 15. But that seed was planted, and then at 21 they were maybe able to do some, put some of those things in place. It was just a better time for them to do that, but that seed is there. So yeah, don't give up.
Yeah, they also like to explain things to you. Like, they all assume we don't know anything as older people. So if you can be like, explain it to me like I'm 5, lots of them love that, in terms of like, or like, yeah, what are you looking at? Okay, what's that music about? Okay, okay, or they'll say something, I don't know, some manga comic. I'll be like, explain it to me like I'm 5, right? And then if you can get them talking, I think even if you didn't get much done in that visit, I think it sort of uh can kind of loop them in a bit for the future. And you're
Okay.
still going to be that person who was just accepting and chill, and didn't try to force them to do something they didn't want to do.
Yeah. Okay. Awesome. Well, this has been great, guys. Everybody else is shy, obviously, so thanks for indulging all my questions. But I just want to thank you also for the last 4 weeks. I mean, I've really enjoyed it, and I've received some great feedback from participants sort of offline. Allison's coming in. Yay, Allison! Good to see you. And she enjoyed the sessions very much. Yeah. Well, I don't know, Allison, you had pretty vast experience in this space, so it's awesome to see you here. Thank you for coming, and thanks to everybody for coming. It's really great, and I've certainly enjoyed it, and I think everyone else has as well. So, thank you so much, guys, for all the work that you've done on the EOSP and all the various contributions you've made in the space and the coalition. And yeah, we're really grateful for all your expertise. And as I said,